You're listening to the Medic Materials Podcast, hosted by Mike Turek, Emily Yates, Kelsey Coons, and Gerard Cuomo. All are current EMS providers and educators with a combined 30 years experience. Each month, we discuss EMS news, medical science, and review actual EMS calls, bringing many educational opportunities to the listener. Portions of the calls have been altered to protect the privacy and identity of all involved.
Hello and welcome everyone back to the Medic Materials Podcast. My name is Mike. I'm here with paramedic intern Kelsey, Gerard, and Emily as always. And we're going to be getting back down to business here and talking all about a very interesting call review that was sent to us by a crew. And it's fairly short. However, I think the educational points on this and the conversations that we can have are fairly intriguing and interesting. So, Kelsey, I'm going to toss it right to you for the rig check so we can get right into this call review.
So, guys, we have officially reached over 760 subscribers on our YouTube page. So, thank you to everybody who has subscribed. Our next goal is to hit 800 subscribers. And that's a big number. That's like almost 1,000.
It is like almost 1,000.
It's almost like you're right.
But you think about that, think about being in an auditorium with 800 people.
Thank you for the stage fright. I appreciate it.
It's YouTube, not here.
Cool. It's so freaking cool.
It is cool, and we thank everybody. It's really cool. Yeah. No, I'm still like, wow, that's a lot of fucking people.
It is. It's so freaking unbelievable.
They all love you, Gerard.
They do.
That's misplaced.
Okay, guys, students or acting providers, do you have a topic you want to discuss or a subject that you want to learn about? Message us.
She just wanted to.
What else was I supposed to play that off as? Message us
Are you having a stroke?
That's a prime example of the sound of a brain fart.
You can message us at medicmaterialsedu on our Instagram and Facebook, or email us at info@medicmaterials.com. And today we'd like to shout out our listeners in Washington, France, and our Patreon listener, Dustin. Thank you guys for supporting us.
Woo! So, like I said, this one's, a fairly straightforward call, but there are some things that we, like you said in the last episode, Gerard, that you really have to do some critical thinking about. And I feel like that's where this call really gets you, right? So the system that we're going into is a rural EMS.
We're doing it now?
What?
We're doing this now?
Yes.
I thought you had a dental appointment.
That's why we're rushing.
Oh, I'm sorry, my bad. I thought it was 1 o'clock. I'm like, dude, you need to fucking go.
We got time. We're good.
Rock on. Not bad. I was looking out for the young girl.
I know you were.
Wait, she's looking out for
Nobody was saying nothing. I just gotta wait until my dog starts barking because eventually the Terminex guy is gonna be at my door.
All right.
So
hey, get him a mic.
There you go. So
he's like Dale Gribble. I'm sorry. Go ahead.
So the system that we're going into today is a rural EMS location. It's covered by a small private ambulance company that runs an ALS transporting ambulance, staffed with an EMT basic and a paramedic. Hospitals in the area, there's a small community hospital approximately 15 minutes away from this call's location, and they are literally community hospital. Don't do much. And then there's a cardiac stroke center approximately 60 minutes away. So an hour away. Your initial dispatch is priority 1, a Delta priority, to a private residence for a 59-year-old male with complaints of chest pain. So fairly straightforward. I mean, this is one of the most common complaints that people call for, right? So the crew arrives at the house and is let into the home by an adult male who appears extremely diaphoretic and ashen. The crew. Went minion.
That's
there
what I was thinking of.
The crew asks if they're there for this individual, and he replies yes. He then shuffles back. Right.
They actually had to ask.
They ask.
Right. It's going to be something even worse.
Can you make sure if he said no?
No, it's for the other guy.
Oh boy.
Wow.
I mean, and it's so funny because like I'm writing this and I didn't even think twice about that. Like, because we do it all the time.
Right, yeah.
Like, but so true. Like, are you the worst one?
Call 911.
Like, right.
Yeah, he's cut in half. Yeah, call.
No, she stubbed her toe.
So
Only finds the flesh wound.
So after this gentleman replies yes, they are there for him, he shuffles back into the house and the EMS crew just steadily follows him.
Good for him for getting up.
One thing,
Wait a minute, if he can ambulate, don't walk that way, walk this way.
exactly, that's what I was
Have a nice
thinking.
stretcher waiting for you.
That's exactly what I was thinking. Like,
Tell
why
me
are we
more.
letting him go backwards? Let's go forwards. Especially looking super diaphragmatic and ashen like shit. So
Stop walking! Don't! Shit!
So he finally sits down in the kitchen where the EMS crew begins an actual conversation with this guy. And he tells them that he woke up a few hours ago, and shortly after taking his daily shower, he developed a crushing, sharp chest pain. This pain has continued for the last few hours without any change or improvement. So I want to go a different route here in my first little discussion with you guys.
Oh.
Kelsey has started paramedic school. I want to know from paramedic Kelsey, what is concerning to you about this presentation thus far?
I mean, I feel like it's a good sign that he's up. Not that great, but he's up and he moved. But I feel like the fact that he's diaphoretic, the crushing chest pain, all of it just screams like, okay, this isn't good and I need to figure out what it is quick.
Okay. Any other thoughts? Are you with her on that one?
Oh, I'm with her because you can't, not that people would fake chest pain, but you can't see chest pain, but I can see you turning pale and covered in freaking water.
I
Right.
can see
I was
the
gonna say.
after effects of prolonged chest pain.
We know there are some reasons that go along with the chest pain that can cause that. So
Yeah.
in my mind, we need to do things Ricky Tick.
Ricky Tick.
Ticky Tavi.
So
Or that too. I'm a Mongoose fan. What can I say?
So the
A reference that somebody else gets.
that is true. She did get one. So the EMS crew begins their initial physical exam. They find him to be conscious, alert, oriented ×4, airways clear, free of fluid and debris. Ventilations are normal. Lung sounds are clear and equal. And peripheral pulses are present and regular. So fairly okay through the ABCs.
Both sides.
Bull sads?
Pulses on
both
both
sides.
sides.
Okay. Can't say I've ever heard of that one.
No, I heard her say both sides.
I
Both
didn't.
sides. That's what I said.
No.
Both sides. It sounded
Is
like
it a
both-
question?
it sounded
What
like
it's a
both sides.
question.
Hold on. What did she say? Both sides?
Both sides.
Like
Bilaterally.
BOTH?
Yes.
See, I heard bull sides.
So did I.
I was like, what the fuck acronym are you using that I have no idea what it is?
I heard that too, but I understood what she meant.
I didn't.
That's even scary. I'm like, both sides. Yeah, I know what she's about both sides.
Nope.
Sorry,
That one
guys.
went zing right over Turk's head. Yes, equal peripheral pulses on both sides. present
Bilaterally.
and regular.
Sorry, I'll start using bilaterally instead. You can't screw that one up.
So, skin is cool, it's diaphoretic, and it's ashen in color. The crew noted that while he is sitting in the chair, he is wincing while clutching the center of his chest. He's doing that Levine sign, that like closed fist clutching right above your sternum. Not a typical good presentation for cardiac patients, right? The EMT sets up the cardiac monitor and obtains a baseline set of vitals. Blood pressure via the NIBP cuff returns as 190 over 130. Heart rate is 90 via the pulse ox probe, and the oxygen sat is 99% on room air. Respiratory rate is 16 unlabored, and he's complaining of the 10 on 10 sharp crushing substernal chest pain. So
If this turns out to be a UTI, I'm gonna fucking kill you.
That's more common in women.
I'm no. Let's put it that way.
Thank you.
You can write that out of your
Right.
diagnosis box. Okay, so where's your guys' heads at? So like you've been gathering all of this information, haven't spoken very much, but like where's your head at? Any initial diagnoses that you're looking at in this point?
I mean, not good. Keep moving.
Okay.
Yeah. Yeah, I'm gonna go straight to, my freaking cardiac protocols. I'm gonna, IV 12 lead. I think at this point, I probably already have enough to go on to, let's break out the nitro and the aspirin and get that ready to go.
Okay. I agree wholeheartedly.
Yeah.
So this paramedic begins to set up the EKG leads while the EMT's beginning, the attempt to gather more information, right? That whole medical history that we love to get. The initial EKG rhythm shows a sinus rhythm in the high 80s. And during that time that they're getting the sinus rhythm, he tells the EMT that he's got no allergies and that he doesn't take any medications currently. He explains that he has not been taking any of his prescriptions for the past year. He has them. He just doesn't want to take them.
Why?
So he explains further that he's been in a dispute with his doctor to the point where he's just been like, fuck off, I'm not doing what you say. And refused to refill his own prescriptions.
What were they?
We're getting there. So
We're getting there this time, not like the last one.
So, Pat,
I'm just gonna go on a limb here and say that his doctor was probably right.
oh, I probably would agree. Like, it doesn't sound like this guy
It's
is
not one of those the customer's always right situations.
Yeah, no.
I think where we're at right now kind of proves that
Right.
was probably correct in his thoughts.
Probably, right? So he's supposed to be on where the hell is it here in my notes? Metoprolol, another beta blocker that he stopped taking. They put him on the metoprolol. He stopped taking that. I don't have the name of the other beta blocker. Then he's on losartan, and he is.
Amlodipine?
Huh?
Nothing.
I was
Nope.
just gonna say it's
Yeah.
trifecta.
Right?
Nope,
The trifecta.
nope. He's not actually on the trifecta, which is interesting. He's on the daily baby aspirin, and that's it.
Time out. What is the trifecta?
Beta blocker, an ACE inhibitor, an ARB, and calcium channel blocker. Amlodipine's like the first line for everything.
Amlodipine, losartan, metoprolol.
Or amlodipine, losartan, lisinopril.
Lisinopril. Yeah.
Yep.
What does that mean?
It's a blood pressure regimen.
Yes.
Oh, so it's just like a constant. There's not like a, oh my God, he's on this and now he's got chest pain, so he's going to die. Like,
No, it's just like
a,
they actually have high blood pressure.
Right.
Oh, okay.
Yeah. So moving forward, past medical history, he's got multiple cardiac stents after multiple MIs, myocardial infarctions, and hypertension. Okay, which we've already figured out at the table. Okay, so the paramedic obtains a 12-lead EKG, which returned as a sinus rhythm. Now, I'm going to change up here.
No
and
depressions or elevations.
so here's what I'm going to do.
Well-
So I actually got the EKGs from this crew. And I want you guys to actually look at it here on my tablet. We're going to take a break here for 2 seconds. I want you guys to look at it because
Kelly will entertain you for the next few minutes.
I want you guys to give your opinions because it is super interesting the way this come on, you can do it. This thing gonna be stupid. Okay, so this was the original EKG. Okay, I want you guys to look at it. There's, it's gonna be wonky, but so
Oh, it's upside down.
the way they scanned it in is all fucked.
Oh, what are you doing over here?
No, I was on with you. I was on with this. Oh no! Wait.
Oh, you want to record it?
You want to record?
Yeah.
Oh, I thought we were taking a break.
No. I want. This is part of the show. I want you guys to actually tell me what you see.
Poor Kelly.
Rude.
Like she had a moment to shine and you just snatched it from her.
Yeah, exactly. She is not important. So you're looking at the original EKG rhythm here.
Yeah.
And in your opinion, sinus rhythm, yes or no?
It's sinus.
Okay. Where is there depressions, elevations, anything that you guys are seeing that would pique your interest? Let's put it that way.
Well, the wide T's, the inverted T's in AVL, and then the inverted QRS in V2. What else we got here? Slurring, a little bit of slurring there. In V3, V4.
It is
It's a
a
small
hard
screen.
it's a hard thing to read
And
too.
it's like backwards.
Yeah, it's very hard to read.
It uploaded funky.
But from a standpoint of if this
there's
is
a
your
couple depression. Well, I mean that's not even it's on the line there too.
so from a standpoint of being an ALS provider, if this was the initial 12 lead that popped out of your machine, what is going to be your thought process afterwards? Because I was going to take a little snapshot and post these just so other people could see what we were looking at. What are you like? Is this concerning to you? Does it match with his presentation at this point? No. Right? So you guys would have assumed there's going to be humongous elevation somewhere in the ST segment.
Yeah, I would expect
right?
tombstones and all the good stuff. Yeah.
Right. Whereas here, can you really determine is it even off the isoelectric line? Like maybe there's 1 millimeter of elevation
if that.
here or there.
Yeah, if that.
It's
not consecutive.
They're right. There's like one beat here that might have 1 millimeter of elevation, but it's not like a contiguous strip or even a contiguous section. So moving forward, the monitor, because we always get the monitor readout, right? On whatever monitor you're using, it spits out the printout, right? You
should only ever read what it spits out.
Always, right?
Yeah, don't worry.
Somebody's going to listen to that, and that's going to be their new mantra.
Yeah.
Well, you told me to.
You just listen to Gerard.
Yeah.
We'll sign it. I don't know why he died.
So this computer, this monitor, whatever monitor it was, I don't know, spits out the inferior wall STEMI alert. Okay. The medic looks at it, looks at the tracing, and their thought to me was there's a possibility, you guys saw it, possibility of like a 1 millimeter elevation in 2-3 AVF. That's what they said. I'm still on the fence looking at it going, is it really? I didn't really see it. But that's what this paramedic went with, right? And there's no reciprocal changes, right? Like I didn't see any type of reciprocal changes or anything like that. They also see that. So moving forward, the EMT gives him 324 of aspirin, right? 324 milligrams of chewable aspirin. Awesome. So I've already asked Emily, you had said these signs and symptoms are not consistent with a STEMI. However, with the computer generated rhythm, it's saying STEMI alert.
Wait, hold on. These signs and symptoms aren't consistent with a STEMI?
No,
I'm saying
he's saying is the 12 lead is
I
not
got you.
consistent with his signs and symptoms.
I thought he said the signs and symptoms weren't consistent with the
With
STEMI.
the
alert.
12.
I probably did and didn't mean to say that.
All right.
Yes.
All right.
The EKG does not is not consistent with signs and symptoms of a
with
STEMI.
the presentation.
Right. So what do you guys believe is going on with what you're told so far? Like, what is your next step here?
I'm going to call a cardiac alert, and
I'm still thinking
We're
cardiac.
Yeah, everything there is screaming to me that this is plus his history.
Mm-hmm.
I'm looking at this. I'm going to call the alert, and we're going to go to the cardiac center.
Okay.
I think especially since you have that long drive, move now.
Mm-hmm.
Go.
Right. Do you guys Are you still on just a overall cardiac thing, or are you narrowing it down to something? Like, is this just, I'm going to think cardiac, or I'm thinking, yes, this is probably like an NSTEMI or a STEMI that I just can't see. Yeah. You know?
That's what I was going with.
Okay.
Does he have any swelling anywhere?
No. No, he does not.
I'm going to start my...
Do we have any other history on him?
Nope.
He only has the cardiac stuff.
Only has the cardiac stuff.
Yeah, I'm going to start him on nitro, and we already gave the aspirin.
Do you believe that blood pressure?
I was going to say, I want one more to confirm it.
I mean, 190s over 130s.
That's consistent with what I would expect.
But if are you then saying that if he's having a STEMI or even an NSTEMI, depending on where it is, he could be hypo or hypertensive? I mean, if it's in the inferior section, he should be hypotensive, right. Not retardedly hypertensive, right?
Medical term.
Yeah, but is his normal like 260?
Well,
he hasn't taken his blood pressure meds in a year.
He hasn't taken his blood pressure meds in a year, right? So now you can clearly say he's uncontrolled hypertensive, right? So lots of different things that we have to start figuring out which direction to go in, right? No one is wrong at the table with anything that anyone's thinking. So the EMT goes outside, grabs the stretcher, grabs the stair chair to begin extrication process. They move him outside, they place him in the ambulance. And once they're in the ambulance, the medic places an 18 gauge IV, left AC, awesome, successful, cool. Vital signs are taken again. BP via the auto cuff again is now 200 over 120. Heart rate is 85 via the pulse ox probe with 100% oxygen saturation. Remains in a sinus rhythm. Respiratory rate is 16 unlabored. GCS remains 15.
100%
So
on room air?
What was that?
Yeah, 100% on room air.
On room air.
Okay.
He continues to complain of that 10 on 10 crushing sharp pain to the center of his chest. However, now he's reporting a sharp pain developing in his groin area. So I just got a lot of like, what the fuck? I got a lot of weird eyeballs looking at me right now.
I mean, I guess if like you have a clot in one spot, why can't you have a clot in a lot of spots? But I just feel like that was strange.
I'm going to focus on the chest pain.
Okay.
Yeah.
Wait, what was the description of the pain? Just like
of the groin pain?
Yeah.
Crushing groin pain?
No, not crushing.
I was going to say you might want to reposition him on the stretcher.
Seriously, no. This is a constant sharp 10 on 10 pain developing in his groin area.
Any specific part of the groin area?
Like inner thigh or just like groin?
Overall, very low abdomen to like top of the groin.
Okay.
You're looking at me like...
And there's no uterus in there that we don't know about.
Correct. This is a guy.
I'm clarifying.
That's fine. Emily is super deep in thought here.
How long has this chest pain been going on for?
Couple hours.
What was he doing when it started?
He woke up, took a shower, and it started.
Hot shower.
Got a thought.
She does. She's
because I don't want to dismiss the groin pain because I'm sure that there's is going to tie in, but like I don't much care right now.
Okay. I mean,
like,
it's fine to not care.
Keep it in the back of my mind.
Yeah, like it's going to
about it every once in a while.
Like, I think we have bigger fish to fry.
I can say if I was there doing this in real time, on scene, in my mind, my groin is hurting now. I'd probably just assume some kind of refresh.
Tell him to move his ball sack and
right. Yeah.
Hey, you're just probably sitting on your left nut. Right. Move it a little.
Do an adjustment.
Yeah.
I don't think it would hurt to push on his stomach, see if there's any reaction to that, and go from there.
Interesting. Okay.
But I don't think the 30 seconds that's going to take is going to drastically affect the chest pain at all. Mm-hmm. But it might tell you just a little bit more that you're missing.
Okay. So the crew then begins transport to the cardiac hospital 60 minutes away. And one thing that I noticed going over this call was that they did Dever.
He had a bunch of stents, and I'm sorry, I didn't mean to speak over you. He had a bunch of stents and things like that put in previously, right?
Yep.
And stents dislodge.
Yes, stents. And they can reocclude. So, like, literally this entire time, I'm like, why is he not on a blood thinner? Why is he not on anything for cholesterol?
Yeah.
When was the well, never mind, keep going.
He doesn't like his doctor.
So now you see where my mindset is. Okay, go ahead.
No, I think it's perfect. All right, the history is super cardiac driven, right?
I feel like I'm gonna get tunnel vision on this and miss something.
I'm sorry. They don't get a blood sugar, so it's okay. So
and there's no wet bandage.
Fuckers.
Right.
and there's no wet bandage. So the crew begins the transport to the cardiac hospital an hour away. And one of the things that stood out for me is they never think about utilizing air medical.
I was thinking about the same thing.
Like never think about it, mention it. Like I asked and they were like, nope, we didn't even think about it. We just started hoofing it.
I don't think I would either.
I don't think I would either. Like, there's no clear-cut sign for it. Like, not that I believe in idiopathic chest pain, but idiopathic chest pain sitting over here.
There is plenty of sign for it, right? Like, yes, it's not on the monitor, but Levine sign, the crushing, chest pain, now, 10 on 10, no relief, with the blood pressures, with his history, with
and
the distance.
Brings one of the things up is like, oh, well, the 12 lead's fine, so we're fine. That's a very small part of what tells me if you're having an MI or not.
Right.
Very small.
Yeah.
I mean, like I said, everything else is screaming MI. And okay, so he doesn't have the exact, 12 lead that says, okay, this is exactly what it is.
All of the pieces are not going to fit all the time.
Right. But it would definitely be something that I would consider.
I don't think it's wrong. I don't think that would have crossed my mind either.
I've flown a Stemi.
Yeah. And from 60 minutes out, a 60-minute drive is about a 20-minute flight.
I mean, time is tissue.
And you're looking at, okay, you want to go off 10 minutes to land, 10 minutes to get off the ground and land, and then another 10 minutes to get off and do whatever. So you're looking at 40 minutes that they could be there in the cath lab, or 60 minutes for me to drive there. Yeah, you're still saving 20 minutes, and time is muscle.
I mean, from where we were that time when I did it, it was like an 8-minute lift with like a 5-minute en route time.
Yeah. And
the LZ was actually heading in that direction anyway, so I was like, yeah, I'll do it. Just do it.
Yeah, I mean, it's definitely something to consider, that you can fly these non super duper, calls. So the medic decides to drive. They start driving.
The medic drives?
No, the EMTs drive. The crew decides to drive.
Oh, be Austin.
Yeah. Totally. So en route, the medic, this was kind of weird. The medic first administers 100 mics of fentanyl. Right? IV along with 4 milligrams of Zofran IV.
That was the first choice?
That was the first choice to do.
Not nitro.
Right?
Huh.
However, after, I'm looking at this and I'm getting the story and I'm like, I'm scratching my head and I'm going, what the fuck? Like, what? That is not ACLS at all. Like, that's not even, that's not Mona, that's not nothing, whatever. However, when they talked to me about it, they gave me a really good reason. And I was like, okay, I can kind of see your reasoning.
The pain
right?
chain.
No. So they deliver the meds, right?
Okay.
They deliver the meds, and they say to me that they want to deliver the nitro for the chest pain, but they want to do a right side 12 lead first because they were seeing the, elevate the 1 millimeter elevations, we can air quote, in 2-3 AVF. So they're thinking maybe possibly there's some inferior wall involvement. Okay. We'll do a right side 12 lead. And I was like, brilliant.
Right.
Cool. So
I would have given the nitro. Mm-hmm. You have room to play.
Yes.
But yes.
Yes, you do.
Cool.
However, I'm never going to fault anybody for doing a right side 12 lead. Right. Never.
Not when you have 60 minutes.
Right. Exactly.
Plenty of time.
Plenty of time. So they do the right side 12 lead, and they do it where instead of just moving V4 and making it V4R, they did a full on, switched 1 and 2, and then did a whole new set of
this is going to show
stickers.
the massive STEMI.
Mm-hmm.
So
flipped AVL.
I have that feeling.
This is.
Yeah.
So this tracing, no definitive ST elevations.
Oh, what a letdown.
Damn it, why couldn't you be dying? Nothing.
He's definitely dying.
Absolutely nothing definitive ST elevation wise, no ST depressions, no nothing like that. So the medic then with this finding goes, yep, nitro all the way. Right. So administers the 0.4 milligram nitro spray under the tongue, and 5 minutes later rechecks vital signs.
Tanked.
BP comes back 190 over 121. Heart rate still sinus in the 90s. Pulse ox is still 100%. Respiratory rate still 16. Right now we're gonna jump forward 20 minutes.
Jesus is watching you when you say 16.
Yeah. So we're going to jump forward about 20 minutes in the call because nothing really happens, super amazingly.
Just continue nitro spray.
Right. So after 20 minutes, 4 sprays of nitro, his pressure pretty much remained above 183 over 113. That was the lowest blood pressure in that 20 minutes. Okay. The medic now sits him forward and does something that I'm going to steal a phrase from Kelsey, made my heart happy, because you never, ever see this ever.
I'm like starting to think maybe there's something including somewhere. Yeah.
This paramedic did a posterior 12 lead.
No shit.
And I was like, oh my damn.
Hell yeah.
It's like, that's some Mark Foster level fucking shit right there. Like,
Yeah.
I don't even do those.
They're really searching for this STEMI.
Right. So the posterior 12 lead comes back and shows
Absolutely nothing.
Hairline ST elevation in 2 and 3. So it's, I can pull it up if you guys really want to see it, but let's put it this way. It was like
the smallest unit of measure on a construction site.
Yes, you have 4 beats in 2-3 AVF, and maybe 2 of them are barely at a millimeter and a half. Okay, so it's nothing definitive. It's nothing definitive. It's not like screaming, "Oh, hey, I got tombstones here, there, and everywhere."
Did we do a repeat of a normal EKG?
What do you
we're
mean?
just putting stickers all over.
Oh, we're just doing
We're
stickers.
giving them a Brazilian.
Yeah. Yes, and still
Nothing.
Yeah. So
The only good thing about it is if you leave all the stickers on, you can just keep moving the leads. And
That is true.
yeah. So you guys are thinking really hard through this, and I want to break and I want to kind of gauge what the hell are you thinking?
I don't think if any finding came up on the right-sided or the posterior EKG, it would have changed treatment plan, or it shouldn't have.
Yep.
Yeah.
So I don't think, kudos to you for doing that,
Mhm.
100%. I just don't think I would have looked that hard.
but don't you
It's
think it
still
would have
cardiac to me.
benefited their care in the hospital?
Why?
Because wouldn't it be
How many
more definitive?
right-sided or posterior 12 leads do you think is done in cardiology? I work at a cardiac center.
No, but I'm saying, like, would it have helped future, hey, by the way, this is where I'm seeing the elevations?
No, they're going to go up and get a cath and they're going to find exactly what vessel.
It doesn't even help pointing them in a
No.
direction.
Neurological deficits of any kind.
None.
I know, that's almost
GCS
what I'm
of
thinking.
15.
Equal weakness. Equal
Especially with
weakness.
4 sprays of
weakness,
nitro.
equal pulses.
And
Strength,
staying
I meant.
that high.
What about his groin? Does that still hurt?
It does.
The fentanyl didn't help?
Did we push on the stomach?
Nope.
Is swelling happening?
No.
Discoloration.
Then I still don't care.
He's still ashen.
No, I'm talking about like his abdomen.
No.
So he has had no relief with any interventions.
Has anybody looked at the groin?
Nope.
That's for Corey.
Yeah, there's a story there.
Huh.
Emily can give him a scrotal swing if he would like.
I'm very good at scrotal slings.
I don't even. Not even going there. So
If I don't sling and swat, I hate you damn sure ain't doing a scrotal sling.
exactly. Right. So, as you just asked, he continues to complain of the 10 on 10 crushing sharp chest pain. No relief whatsoever. Now he's 5 nitros in. He's 100 of fentanyl in. He's 324 of aspirin in. He should be feeling something by now.
Right,
Not
anything.
that I was just saying,
Possibly.
I mean, not that. I've used fentanyl for cardiac stuff too, but
Morphine.
yeah, what was the thought process of not using morphine in this?
Because they hadn't gotten the right-sided yet.
That's
Okay.
a
It's
possibility.
less
I didn't
vasoreactive.
honestly.
Yeah.
It didn't
My
ask.
guess is it's less vasoreactive. They didn't want to touch his pressure until they got the right sided.
Okay.
It's a
Same reason
possibility.
why he didn't. I don't know. I'm gonna
give
go
the
with it.
nitro
I mean, if
beforehand.
he's given nitro, yeah, all right.
Now he is though. He didn't give it at
Right,
first.
didn't do it before.
Right.
Yeah, okay.
So he continues to complain of the 10 on 10 crushing sharp chest pain. The groin pain is still present.
Is it worse?
It is worse. It's now equal to that 10 on 10 chest pain. It's now just 10 on 10
Is he
groin pain.
dissecting?
And
I'm starting to
he's
think that.
So that's why
And
I was
with that
asking
ashen
about
color?
equal pulses, because wouldn't you see a change if it's like one way or another?
You would have a different blood pressure on each side.
I've never had a dissection live long enough to take a blood pressure on each side. So
Okay.
sure, in theory,
okay.
But I'm starting to think
are they
yeah,
dissecting?
I'm
Are
sorry, that's what I'm
they?
starting to think.
So
Does
let
he
me
have any pain in his legs or just his groin?
no pain in his legs.
Do you
Just
have
in
a
his
description
groin.
Of tearing sensation.
Nope.
Just crushing.
Sharp crushing chest pain.
What about, does it go to his back? Like,
Now
ah,
literally, the next sentence I was about to read. He now begins to describe a feeling of his chest
Yeah.
pain moving into the center of his back.
Yeah, it's dissecting as we're watching it happen. Yeah.
Okay. So
So why doesn't that show up? I get
eh,
question.
eh.
Sorry, question.
Right.
Wow.
So like when the I
She's
don't
having like neurological issues.
Yes.
Today, you know.
yeah, it's the diesel to my brain. Just saying.
Diesel brain.
So I guess like I don't know why my first thought when there was nothing on the 12 lead was like, maybe it's something like that, and I don't know why that was my first thought. But why wouldn't that show up on a 12 lead? I understand it's like the electrical activity, but if there's an issue with the heart tissue itself, the electrical activity wouldn't go.
What are you saying? Why doesn't that show up? A dissection?
Yes.
Because the dissection is after the heart.
Right. It's not.
It's the blood vessels out of the heart.
So, it
So there's
wouldn't-
nothing
For all intents and purposes, the heart is
changing.
fine.
And so you can see on EKGs structural changes based on how the electrical
Yeah.
activity changes. There's no structural difference. It's still pumping the same, but it's pumping into a vessel that has a giant crack in it,
Okay.
And those weird anomalies.
or a balloon or whatever.
And when I was even thinking some of the weird anomalies we're seeing on the EKGs, probably from the previous stents and damaged tissue.
Mhm.
Which you would actually think if he's had that many stents that it would look a lot worse.
Right.
Yeah. You know.
So it's
You-
actually a really good
and
one
even
comparatively.
thinking, there was no long Q waves. There was no nothing that, showed previous MIs or infarct or nothing on those EKGs. Going
Apparently his doctor was right all the time back then. I mean,
Yeah.
what the fuck? Take
I
the
mean, now
pills.
too,
take your pills.
where do you think the dissection came from?
Right.
It's
yeah.
uncontrolled
Is
hypertension.
yeah.
uncontrolled
Your vessels
hypertension.
can only take it for so long.
So, the other thing to just note on is, yes, there's no structural changes with a dissection or something like that within the heart, but think about all of that blood is now going not to be returning as preload, right? So you're limiting the amount of preload, which is ultimately going to create a hypoxia state within the heart. So yes, it is true that there's no actual structural changes within the heart, but that doesn't mean that down the road, if they're still living from their dissection, that they won't
That
get
they
an
won't
MI.
have them. Well, 100%.
So you still might have a dissection, but you also have an MI as well.
Right.
Right.
Because all that hypoxia, because your preload is tanked.
But it also makes sense why he's so diaphoretic and ashen with really like no
with a
no
skyrocketing
changes.
blood pressure
Right.
and no relief.
And no changes. Like his body knows already he's in deep shit.
Yeah.
Right. So transport, continues. Medic
This
gives.
is where that helicopter would have been really helpful.
You know, now I'm
Really
kicking
helpful,
myself in the
yeah.
ass for not
Right.
even considering it.
So transport continues. Another 2 doses of 50 micrograms of fentanyl is given. No change. Multiple more doses of nitro spray are also given. Again, no change.
Can I get a blood pressure on both arms?
No. Blood pressure remained above 169/110.
Does it change your treatment plan?
No, but I want to know if it's
Then
really
no, you
true.
can't have your orthostatic motherfucking vital
I
signs.
just wanted to know.
No other changes to the 12 lead. Yeah, they do repeat 12 leads. No other changes. The medic, I guess because they felt like doing stuff. I don't know exactly why they did this. A second IV started, 20 gauge, right forearm. No fluid was ever given.
I would have done that.
Absolutely. Yeah.
With
I
a
mean-
suspected, Did they suspect a dissection?
I don't think so.
Okay,
Because
if I was suspecting a dissection, I absolutely would get another line.
See, that, yes.
I'd already have the bag ready to go.
Yeah.
You know,
Connected,
like,
just not running yet.
Right, just not running.
yeah.
Yeah.
Right.
So they call, you know, an incoming radio report to the ER,
Might even
and
mix the levo.
maybe, yeah.
Just have it mixed
Pop
and
the
ready to
levo.
go. Yeah.
They give a report to the ER, and they're literally, you know, go to the cath lab. When they're in the cath lab,
Dissection.
Terrified me.
when they're in the cath lab, the cath team doesn't actually see any elevations.
Probably not.
So their thought process too was actually, hey, this guy doesn't need a cath lab, he needs an OR. And they were prepping him to go to the OR for a possible dissection.
Yeah.
So I don't know whether or not they, you know, actually found a dissection.
What?
We don't have the
However-
answer
I
to
don't.
this?
However,
Bullshit. Malarkey.
here's what I can say. Reviewing this call, talking to you guys about this call, the possibility that this is not a dissection is
Slim.
not even slim. It's lower than slim. You know?
Anorexic.
Yes, it's you know, bulimia and anorexia together, right? So, what are you guys
It's
overall
Celine Dion,
like?
let's be honest.
What do you guys like overall thoughts with how this call went?
That guy's really lucky he even made it to the hospital.
I agree.
Yeah.
Like somebody was looking out
Especially-
for my guy.
Having it for a couple hours at home and then having it for an hour while driving. I mean, good gravy. I'm surprised he didn't just tear and
Yeah.
be gone.
See all that arteriosclerosis, it comes in handy. It toughens up those.
But no, like, you know, really,
Makes
like,
my arteries like cement.
yeah. You know, what are you guys like critically thinking through this call? Like you guys did. You
I
know,
think
there was a change
He
at
did
one
everything.
point.
Yeah,
I was going to say, I also don't think I would have treated it any different.
Yeah.
I mean, he kept treating the chest pain, the nitro, bringing down that pressure. That's the most important thing he can do
I think
pre-hospitally.
Yeah, I think somewhere down the road, you know, once it started moving into the back, and I'm, you know, now I'm noticing a pattern where, okay, we now have the pain moving to other places.
Mhm.
That's what I was thinking.
So maybe somewhere along the way, I might have put two and two together and thought of the possible dissection, only because I've seen one before.
Yep.
And,
But how many people wouldn't?
Right.
Yeah.
You know?
You know, exactly. I mean, and if you haven't seen one, I mean, yeah, it's going to present like you're, okay, he's having an NSTEMI. You know,
Right.
I did everything I could. I'm
Well,
not showing
and they also
anything,
say, how
you
many
know.
times have you heard tearing chest to back pain?
Right.
Well, it was sharp and, you know, pressure.
Crushing, yeah.
So
Right.
that's not.
Right.
So
yeah.
if you've never seen it, how would you know?
But my thing was the minute it spreads somewhere else, like either you're throwing another clot and you are having an MI or something else is going on. Like I feel like heart attacks usually don't lead to groin pain, but like you do have an artery that runs down there.
Yeah, what really started to make me want to scratch my head a little bit more was the no reaction to the nitro.
To anything.
Right.
Yeah.
Yeah, and it's like, wait a minute, I'm 4 shots in, and he's still cranking out this BP.
Mm-hmm.
Let's start thinking of some other things.
Right.
Right.
That's,
You know.
we were,
Yeah.
And you guys
Giving
were
the stare at each
literally-
other.
right? and that's where I was watching you go and be like, this isn't making any sense anymore. Where else can we go with it? And that's, you know, that was one of the educational
I mean,
points
don't
that
stop giving the nitro. Continue
Yeah.
doing what
Right.
you're doing. I mean, because we could be wrong. you
right.
know? I
Well,
mean,
and
who
that's
knows?
it. You
my
know,
x-ray vision's
Right,
broken.
Exactly.
right. And you
The
know,
crystal diagnostic ball.
that was
The magic OJ8 ball. You know.
you know, something that I wanted to touch base on in just the educational points of the episode is that, you know, if your treatment is not working, it might be that you're treating the wrong thing.
Reevaluate.
Right, reevaluate. You
Yeah,
know,
don't
and this
think
isn't just,
yeah.
you know, cardiac or whatever. This is,
Everything.
you know, respiratory or whatever. You know, if all of your respiratory stuff isn't working, well, then maybe it might be cardiac,
Yeah.
and it's causing respiratory issues. So look in other places. You know, always look in other places is my thought process. You know, until I can definitively say, yeah, it's down this road.
Right.
But especially if something isn't working or it's taking a forever time to start to work, you have that time. You should be thinking about other possibilities. So that was the first big thing.
Yeah, I would just say along with that is, don't dig your heels in.
To one.
Right.
That's what I was just going to say. Don't get stuck on one diagnosis.
Well, I decided it was this, and that's it. It's going to be
yeah.
it. No, I mean, you got to
keep an open mind.
Yeah, keep an open mind and know that we know nothing.
Right.
Hey, you want another mantra? There you go.
Yeah. We all suck.
We all suck. We don't.
How did that not come out?
Right?
Whoa. That's true.
Yeah.
Wow.
Damn.
But yeah, when you start seeing, hey, it looks like a duck, it walks like a duck, but it sounds like a platypus. Like,
what does platypus sound like?
Maybe we need to. I think you made that sound earlier. Maybe it's time to take that step back and say, okay, what's going on here?
But we said like, okay, we're going to put the groin pain in the back of our mind and we'll come back to it. Don't be like, oh, I'm throwing that out. I don't care.
Right.
Put it in the back of your mind.
How many people would
come back to it?
Yeah. Absolutely come back. There has to be a reason as to why they're. It could be that they're sitting on their left nut, or it could be that they're dissecting
the groin.
Well, that's why I was where it was.
Groin's not here. We can't.
As much as I hate to admit it, I probably would have taken a peek.
Yeah. Yeah.
Almost like it's your job, Gerard.
I would have said that, but yeah, I probably would have taken a peek.
If Corey listens to one episode, I hope it's this one, just to hear that come out of your mouth.
So,
Nope. We're good.
Okay.
We're good.
So I want to go over just dissections very quickly in general, right? So the aorta.
I wouldn't have given them around the world or anything, but
No, that's for your OnlyFans.
That's my only.
I think I'm gonna like somehow create you a fake page, Gerard on OnlyFans.
Right. Oh, if I start getting paid, I'm walking into work and I quit.
There you go. So the aorta as a whole is comprised of 3 layers, right? In a dissection, as you said, a tear develops in the inner lining of the aorta, right? And this bleeding now goes through the other 2 layers. And as the bleeding increases, the aorta begins to literally shear. And the other 2 layers, begin to shear as well. So now you're, if you can imagine, you're literally knife slicing your aorta from the inside.
What a lovely thought.
Yeah. Yeah. You can say.
I have so much to look forward to.
I know. Yeah, I know. So
take your blood pressure meds.
I do.
Yeah. Information
and
for
you
you.
Listen to your doctor.
Then you don't have this to look forward to.
Yep. Information. So there's actually 2 types of dissections: type A, type B, right? Just like personalities. Type A is more common and more dangerous. And that's where, so hopefully.
Gee, who has type A? Go ahead, let's hear it.
So the tear in type A develops in the aortic arch, right? So the aortic arch is right where the aorta exits the heart. And type B is where the tear develops in the lower descending aorta. Now this is down by the, groin or the
my guy could have had a 2-for-1,
right? So this guy could have had a 2-for-1. He could have had a tear that went all the way. But then I would think if the tear happened all the way,
definitely would have been dead by then.
Yeah, right? You would think that he would just die in front of you.
Yeah,
maybe it was a referred type of pain or something like that.
I think you're right. I think it started somewhere I think it was an abdominal aorta. And an abdominal AAA.
Why would that start in your chest then?
Well, I'm thinking it was so it's dissecting. It's starting to bleed out. Of course, he has all this cardiac history. His heart's not getting what it needs, so it's going to start presenting as chest pain.
Isn't type A more common?
Type A is more common. It's also way worse. Yeah. Statistically speaking.
Yeah.
So
But it's more common because it's the highest pressure.
correct. It's the pressure literally right outside
and
of the
it's
heart.
the highest.
It
That's
is
why you
the
always get the
highest
tears
pressure.
there.
So
I mean,
if you
when the heart doesn't get what it wants, it
The fussy
lets you fucking
motherfucker.
know.
Oh, yeah.
It's like, hey,
Oh, yeah, it
motherfucker,
does.
I ain't getting the O2 I need.
Right.
I'm not getting
You
the
might be
preload.
right.
I'm not getting
No,
any
you-
of it.
and
Yeah,
think
that's
you
what I
know
was thinking,
thinking
man.
too about risk factors
And
here.
how much blood can he spit out that isn't getting back?
Right.
In the abdomen.
Especially with a
cavity.
pressure of 190
Right?
systolic.
Right.
Yeah.
You know, so you also have to think about like risk factors with cardiac patients that
Aren't taking their
may
meds.
develop this, right? Uncontrolled hypertension is literally the biggest risk factor for these kind of situations, these dissections. This guy hadn't been taking his meds for over a year.
He didn't
right?
need
So
them.
who knows how high his blood pressure was? You said 260 or
that
whatever
dumb
could have
doctor.
been. Right.
Yeah.
You know, he Googled it. He became a doctor. So
Yeah, I saw it on, freaking Mayo
Grey's
Clinic
Anatomy.
website. Yeah,
yep.
yeah.
Who knows? So
Grey's Anatomy.
Leave Grey's Anatomy out of this. We all realize it's a sham. It's a good sham, though.
I don't know. I've never seen it. So,
911.
uncontrolled hypertension,
I don't know if I ever do something stupid. I'm just gonna say I saw it on Tacoma Fire.
but that's so funny.
I know.
It's so fun. They don't even try and be
I know.
be right. They just try and be funny.
I know. They're nice and swift.
Yep, soft.
Soft. Soft.
Aortic
Salsa.
aneurysms.
Yeah.
Right, aortic aneurysms are a huge risk factor for dissections, as well as atherosclerosis. The hardening of arteries. So, if you see these types of things on cardiac patients' medical lists, there should be some red flag, like, hey, I should do a little bit more investigation into these types of things. Yes, could you have done 2 blood pressures? Sure. It also depends on where it is. You know, if it's in the aortic arch, sure, you're going to see 2 different blood pressures. If it's in the descending aorta, you might not, because it hasn't gotten anywhere
I just
yet.
wanted to see it.
I know.
I know it doesn't change anything.
I'm not saying it's a bad idea. It's actually a good idea.
It is.
However, it may or may not show anything. That's where I'm trying to get to that.
My favorite thing is when somebody looks at you and asks you to do a task, and my response is that going to change your treatment plan? And if the answer is no, then I'm probably not going to do it.
Yeah. Yep.
So like for him, it wouldn't have changed his treatment plan, but maybe it would have pointed him to the right diagnostic if they didn't
Right,
catch on to
would've
this.
been more-
It would have been
a
more definitive.
Yeah.
Right.
So when I walk into the hospital, I go, "Hey doc, here," or "Hey doc, I'm suspecting a dissecting."
And
aorta,
here's why X, Y,
and
Z.
here's why.
Right. Yeah. So the last thing that I want to kind of review is just vital signs and STEMIs, right? We had kind of alluded to it earlier. Typically, you're going to see a specific blood pressure range depending on where the STEMI is, where the actually infarct is. So I did a video on YouTube about STEMI versus non-STEMI, right? And if you haven't seen it, make sure you go watch it. The synopsis is when you have a NSTEMI, a non-ST elevation MI, you're still having an infarct. It's just a partial infarct. It's not going through 100% of the tissue. It might only touch 20% or 5% or 8% or whatever. So you're not going to get that super ST elevation MI. However, if you're infarcting full thickness through the tissue, you're going to get that classic STEMI. So that's why we usually say that NSTEMIs typically are not as bad as STEMIs, because you're not going all the way through the myocardial tissue. Again, I break it down a lot deeper on YouTube. Go watch it.
Sometimes where I brought people in where I'm suspecting cardiac, I've got nothing on a 12 lead, and I don't find out until later. I go back on a second, third trip, and their troponins were up.
Right.
So it was cardiac.
Right.
Yeah, right.
Exactly. Like you
12
said,
leads are very small
12
piece.
leads are very small piece, right? You need
Even
those cardiac
troponins, like-
enzymes. You need blood work. You need all of these other diagnostic tools that show, hey, there was something going on cardiac wise. So typically you normally see normal to hypertensive blood pressures in any of the STEMIs that are not inferior, right? So if you're looking and you see ST elevation MI, in the lateral leads or the, septal leads or wherever, you're typically can sit there and go, okay, well, I'm going to have a pressure that's above 120, maybe it might be 160, 150, 170, whatever. But then you get into the inferior leads and you're like, okay, well, now I'm probably going to be hypotensive. Yep. It could be hypotensive at 90 or it could be hypotensive at 50. Right. It depends on how bad the actual infarct is. But just like there was a call that I did years ago. This was when I was an intermediate and I didn't have access to the cardiac monitor. Like I could put them on it without the EKG. That was literally my access to it. And I called for a medic. This was actually with your husband. And I called for a medic because I was like, this lady, she's having a STEMI. Guaranteed. It was quintessential. Everything that a BLS provider, intermediate provider learns about STEMIs, this lady was presenting with. And I was like, guarantee you somewhere she's having a STEMI. And finally, when the medic gets there, he's like, I don't know. It could just be. I was like, nope, she's having a STEMI. And inevitably, she was having a lateral wall STEMI. And I was like, see, told you, I did that just on presentation and vital signs. She was hypertensive, she was like normal heart rate, maybe slightly tachycardic, and presentation. Yeah, so it doesn't always.
EMTs, yes, you may be. You probably work somewhere where you don't have a monitor. Yeah. You're not doing a 12 lead. You don't know how to interpret the 12 lead, whatever the case may be. But that's why EMTs. We can, at least in this state, the protocol is they may assist a patient with their own nitro administration. Well, don't be afraid to do that. If everything's screaming at you, hey, this guy's having a heart attack. Right. Do it.
Again, sometimes when you're looking for a cow, it's a cow. Right. If it's clear and cut like that.
Right.
Do your due diligence and actually treat your patient.
Absolutely. Don't sit there and go, well, maybe I should just wait for a paramedic.
Who's going to wait? Right. They're on their way.
Yeah.
No, do it.
Yep.
Tissue.
Nitro.
So for you guys, anything else to add on this one? Any last comments here before we wrap up?
No, just don't get tunnel vision.
Mm-hmm. Be open to the possibility. I know. I was waiting.
I knew there was something. I slammed the table
and I was like, damn, she figured it out.
I knew. It's my telltale sign.
That one made me jump because your ring hit really loud.
I did.
And I'm the one who's not supposed to pound on the table.
That's true.
I do it once an episode. Once.
That's true. If she figures it out when she's confused.
I've only figured out 2 of these.
Typically, I can't sit there and stump Emily. She's like, yeah, it's this. And I'm like...
I've only figured out 2 of them. Well, the other ones were just the wet bandage, man.
Yeah, no, that was...
We always go back to that one. That's like your highlight episode. It's great. But till next time, guys, we're going to see you in a couple days on the 23rd on Patreon. So make sure that you go subscribe, sign up to be a salty veteran or a seasoned provider. You'll get access to that. And you'll get access to last month's first Patreon episode. It was fucking hysterical.
It was a good one.
It was hysterical. And the call review that we did was amazing.
And you can make a drinking game out of it.
Oh, yes, you totally can.
Please do.
Yeah. Send it to Emily. She wants.
I'll give you the rules.
Yeah. It's
I
hysterical.
want it on this.
Yeah. You'll see. Just listen to it. You will understand what we're talking about.
Get on our Discord.
That's right. Get on our Discord.
Oh, yeah.
Every Monday, Gerard and I, you guys sometimes show up. We are there. For you guys on Discord. Make sure that, again, that's a Patreon only, exclusive membership deal. Become a salty veteran. You get access to Monday mornings, 10 o'clock Eastern. You get access to us via that Discord server. You can come on and be like, what's your favorite type of pizza topping? Or you could be like, I'm in paramedic school. Help me study. I don't care what we talk about. I'm there for an hour. I will talk about anything with you. Gerard's usually there, so you guys get to actually see what Gerard looks like, which is great. He loves it.
Yeah, he's got a face for radio.
That's right.
You didn't have your video on last time.
Because I have a face for radio.
He did the first day.
That's true. You did the first.
I clicked to join it and I forgot about clicking the other part for the video. So.
It's quite all right. So, guys, till next time, stay safe.
Donuts.
Thank you for listening to today's episode. If you'd like more information on the podcast or to send us a call to review, visit medicmaterials.com/podcast. To learn more information, like us on Facebook at Medic Materials EDU. or watch our weekly instructional videos on the Medic Materials YouTube channel.